Good morning everyone and welcome to our Food for Life Hospital Network webinar. The theme today is food waste, building awareness and reducing waste. And today we're very much going to be focusing on patient food waste. So just to introduce myself, I'm Susanna McWilliam. I'm the Programme Manager of our Hospitals Programme in Soil Association Food for Life.
And I'm Ben Langston, Service Design Manager, and I support the Hospitals Programme as part of my work here. Today's webinar, as you know, is about food waste. So just to let you know that we're going to do some brief housekeeping and introductions. Then we're going to move on to why food waste matters and the policy landscape, which will be introduced by Susanna. And then we'll hear from a couple of our network members about their experiences of tackling food waste in their trusts. And then we'll have a quick Q&A and also just look ahead to some things that we have coming up in the network. So in terms of housekeeping then, because this is a Skype meeting, it'd probably be best if everyone just kept themselves on mute, particularly while you're not talking. If you're one of the trusts who are going to be presenting later, obviously you unmute yourselves then. Just stops any horrible feedback and echo situations happening. And if you have any questions, then if you can use the Skype for Business chat function, which will be on the left-hand side. There'll be a slide in a minute that demonstrates exactly where you can find that. Also, the webinar is being recorded so that those people who aren't able to join us today can still access the content online, and you'll be able to do the same thing and share it with colleagues. And after the webinar, we'll just send around a really brief questionnaire with just 6 questions just to get some feedback from members on that. So introductions, I think it'd just be best if people introduce themselves using the chat function, as I think it's just a bit easier and we'll have less technical issues if we use that function. So the chat function can be found by just clicking on the little chat icon at the bottom left-hand side of the screen, and then you can just type away and send just as you're used to doing with any kind of chat app. So yeah, if you want to introduce yourselves as we go on, then at least people joining can see who's here and who's not here. Okay, so without any further ado, I'll just hand over to Susanna.
So before we hear from our 2 case studies today, just take a minute to think about what we actually mean by food waste, as quite often there are different interpretations in different NHS trusts. So when we're talking about food waste today, we're really talking about any food that's left uneaten and wasted. So that would include kitchen waste, where you're cooking on site or within the trust in a CPU perhaps. It would also include any unserved dishes or meals that may get up to the ward but aren't served for a number of reasons. And also we're talking about plate waste. So when it comes to food waste in NHS trusts, what is the actual scale of the problem? Well, academic studies show that food waste currently is at around 30%, and quite a number of different studies, but overall 30% is a fairly decent rule of thumb. Now that's a lot higher than the national ERIC data would show us. So the 2 different stories going on here. ERIC every year seems to present a slightly different methodology. So this year, actually only 22% of hospitals serving meals reported any food waste at all, and that was due to a change in methodology. So any trust that was sending waste for anaerobic digestion or composting didn't have to report their waste at all. If we look back last year to ERIC 2017-2018 reporting, the reported waste was again very, very low, about 5 grams per meal ordered overall. So we can see here that there's this huge gap between what's actually happening at trust level and what's being reported at national level. And I think currently it means that food waste is very much a hidden problem. So why would food waste matter so much in the NHS? Well, the 3 major impacts of food waste. One is just really simply the financial cost of food waste. Second would be the environmental impact of food waste. And then lastly, the nutritional value that's lost, especially from plate waste. We'll look at each of those 3 things in turn over the next 3 slides. So when it comes to cost for food waste, and this might be the headline that most people are kind of interested in, the fact that the NHS is under such a financial strain, and minimising food waste could be seen as one way to help reduce costs. RAP study in 2013, they looked at healthcare food waste across the board, and their calculations showed that it was about £230 million per year in the UK was the value of food waste, around 22 pence per meal for every meal served. So that included embedded costs of food waste, so for example labour costs of producing meals and production costs as well. Some research that I've done myself in Wales in health boards, the equation of the amount of food waste spread over a year was actually over £250,000 of wasted food. So we can see there that there are huge savings to be made, but at the same time understanding that actually in NHS trusts we're never going to achieve zero waste. So understanding that the starting point being food reduction rather than total elimination of food waste. In terms of environmental costs of food waste, maybe this is an area that's less often discussed, but the NHS long-term plan really commits to an NHS that minimises its impact on the environment and reduces its carbon footprint. So in this slide, sometimes it can be a little difficult to conceptualise what the environmental impact looks like. So we've translated its impact on this slide into something a bit more tangible. So hospital food waste currently represents the same carbon emissions as around 150 trips around the world by car. It represents enough agricultural land to cover 420 football pitches, and it equates to agricultural water consumption of over 12 million litres over a year. So that's quite a staggering environmental impact from food that's produced and ends up going in the bin. But perhaps the most sobering impacts are on patients themselves, as food and nutritional care are such an important part of treatment and recovery. Some studies on the slide here. The top one shows from the House of Commons that perhaps as many as a third of all acute admissions are actually malnourished when they arrive in hospital in an acute setting. So that shows us that the value of food being eaten is really paramount to helping patients to recuperate and recover. But actually, once in hospital, the incidence of malnutrition is found to actually increase. But it's fair to say that vaping showed in 2017 that actually few trusts are tracking and reporting on weight data. So this is still a fairly grey area across the NHS. The third stat there shows that hospital patients with dementia are particularly at risk. And I think everyone's acknowledging at the moment that more and more patients who are in hospital and longer stay are suffering with dementia. And finally, the stats on the screen show that patients admitted to hospital with malnutrition are almost 4 times more likely to be readmitted within 7 days of discharge. So making sure that patients have enough to eat when they're in hospital is really crucial, and we can see here the stark impact on patients who are malnourished on their health and well-being, being in hospital for longer, being readmitted, and of course the knock-on costs of that to the NHS. Before we move on to our case studies from the network members, just a brief update on food policy and how food waste is being addressed. So at the moment there are 2 different kind of policy changes on the landscape. The first is the NHS Food Review that's being led by the Department of Health and Social Care, and that was very much in response to the listeria outbreak last year, or this year I should say. That review really does include consideration of sustainability and environmental impacts, and it's including discussion of food waste within that group. The recommendations from that review are due for publication at some point in the first half of 2020. Then following that, the new healthcare food standards are due for publication in 2020 as well, and they're going to include for the first time some guidance on monitoring and reducing food waste. So I would say both of those policy changes or policy outputs would be very much welcomed when it comes to giving the sector a good steer on where next with food waste. So now I'd really like to welcome Tracy Hugel, Head of Dietetics and Orthotics, and Tim Radcliffe, the Facilities Managers for East Lancashire Hospitals NHS Trust. They're going to talk about their malnutrition prevention project, which includes a focus on reducing food waste. So we're just going to mute at our end and pass over to Tracy and Tim.
Okay, thank you, Susanna. Hello, everyone.
Good morning.
So we're going to talk a little bit about our malnutrition prevention project. This is something that we started in about October of last year, and we were asked to talk on about what we did for the project and some of the barriers that we came up against, so that we can share that learning with everybody.
Okay, so East Lancashire Hospitals NHS Trust consists of 5 hospitals. We have Royal Blackburn Teaching Hospital, which is 750 beds, and is the largest acute hospital in the northwest of England. We have Burnley General Hospital, which is 250 beds, and it's our main elective and maternity unit. We have Clitheroe Community Hospital, which has 32 beds, and Pendle Community Hospital, which has 72 beds. They're both long-stay community rehabilitation units. We are located in Lancashire, in the heart of the northwest, with Bolton and Manchester to our south, Preston to the west, the Pennines to the east, and Cumbria to the north. Our population is around 550,000. This includes patients who live in the most socially deprived areas of England. Just last week, Northwest Food Banks announced record levels of support with a 23% increase on 2018.
Okay. So that gives you a bit of an overview of what we are. So if you can just move on the slide, please. So what we did with the project is we aimed to reduce malnutrition in hospital. And how we were going to do that is we were going to audit the measuring equipment, so the scales on the hospital, to make sure we had the right equipment to measure weight of patients, to then make sure that our malnutrition screening tool was accurate. We were also going to audit the malnutrition screening tool, and that was a whole separate project. We changed how we recorded that from a Caradigm system to ExtraMed, so that was a separate project. I'm not going to go into that today, but if you need any further information, then we can talk through that, so you just contact me afterwards. And then the bit that we're going to talk about today was measuring the food level waste, and what we did with that, and tests have changed to see what makes a difference at ward level. Okay, thank you. So how we did that is we brought together our nutrition link nurses across the wards, and you can see a photograph of those there, and we had a launch day with them, and Susanna kindly came along, you can see in the photograph Susanna's there, to do the presentation similar to what she's done today to set the scene. And then we looked at using the staff that we had on the wards to measure the food waste as a baseline, and then we were working with them to then look at what we could do differently. So if you move on, please. We did get a little bit of concerns initially about the project, so I've just put some of those in here. So there was some scepticism about what we were trying to do, and some of the comments we got were, and particularly from matrons, for example, where we've got lots of pressures on the wards, and concerns that we were using staff to record food waste when they could be doing something else, and scepticism about the fact that is this just a money saving, it's about more than saving money than patient care, and is it a duplication that we're asking staff to complete record charts, and then we're also asking them to record the waste as well. And the nurses already have lots of audits that they have to do. Could it be done by somebody else? So those were the initial comments. If you can move on, please. So our grand plan was we were going to do this, and it is grand when I think back on it. We were going to do this across all wards on all of our 4 hospital sites. However, we had 14 wards attended the launch, and we conducted baseline measures for all of those wards. So we have data on the food waste at ward level for 14 wards over a number of different days and meal times. So actually that probably is quite a good achievement when I look back on it. We also were gathering staff intelligence because we appreciate that not all the wards are the same. So you've got different types of patients on different wards, and different requirements for each of those sort of staff groups, patient groups. So we gathered the intelligence from 9 of the wards, we started to group those into themes, and we've got 5 areas of change which we embarked upon, and we're in the phase of implementation of those changes and re-auditing the waste. So unfortunately, we've only got one area that's done the data from the following on from the implementing the change. So the things that came up from implementing the change, so we put posters up on the wards asking staff to, so we're showing their baseline data and asking staff to comment on what could we be doing differently to what tests of change could we be putting in place. And these were the 5 key areas. So more finger food options for some wards where that was appropriate, and Susanna talked about dementia, which is a key area for this. Real-time ordering. Breakfast trolley would be better rather than patients ordering what they want for the breakfast, having a choice that they could have on the day of it would be better. The portion sizes being too big and over-facing some patients. And one of the quick wins that we had was the spoons were too big, so people were finding it difficult to eat with the spoons. So we were able to procure smaller spoons, and we're gradually phasing the bigger ones out throughout the trust, so that was a quick win. So if you move on the slide, please. So Tim will talk about the challenges of putting some of these changes in place.
Okay, so one of the challenges we had for smaller portions was with the plate size, and we use a plated belt system at our hospital, and the pellets which use those are a set size, and therefore sometimes it was difficult in procuring a plate which would enable it to sit in the pellet but also give a smaller looking portion. We have managed to secure some of those with a bigger lip, which also is better for stroke patients and for dementia patients as well. So the plate size is the same overall size, but the actual surface area where the food will go is smaller. We've also got on the menus, we've also put a smaller option on the menu so people can tick if they want a smaller option. Some of the challenges with that is ensuring that the catering staff do see that and are able to ensure that the smaller portion is smaller than the standard portion that they would put on. So if you'd like to move on.
So with the breakfast trolley, I've put a picture on here, which isn't quite what we were looking at, but it would be great to have. We have had the breakfast trolleys implemented on some of the wards. However, the problems with that is having the storage space to store additional trolleys on the ward areas, because obviously they're usually quite pressured in where the space is. So where we're using them on the wards, and the breakfast trolley is working really well, and they're reporting less waste for that.
One of the issues is the breakfast trolley needs to be returned back to the kitchen every day. So as well as having our standard trolleys which go out for lunch and the supper service, we also then need to store in the kitchen the trolleys for the breakfast service, because they can't store them on the ward. So currently we only have 8 wards which have breakfast bulk service, because we can't really currently store any more in the kitchen.
Okay, if you move on, please.
So one of the options which was talked about previously was finger food, and in March 2018 at a hospital network dementia seminar in Birmingham, the speech and languages, the dietitian team and myself visited, and one of the things that came out there was about the food not being party food, but to be more nutritionally dense. So we introduced a food for fingers menu. We were very insistent that it was called food for fingers and not finger food, so that it was not party food. So we looked at ensuring that there were recognizable dishes that were then reduced down but still nutritionally dense. So they were all over 400 calories. And we had things there which had breakfast muffins, a chicken and veg pie cone. We also have curried tofu bites, which is a new one, and also lasagna, both vegetable and meat. One of the issues we had in introducing that to start off with was that we were only doing it on certain wards, and also it was lack of consistency within the catering staff. That has been eliminated. It's now available across all wards, and it's a lot easier to deal with that when you have one bain-marie on the whole belt, which will enable everybody to choose from. There's been a few tweaks with that, with both a patient survey and a staff survey, giving us the changes of the ideas and also looking at how we serve it.
If you move on, please. So, as I was saying before, we have one before and after. So we're waiting for the others to come in. So this was done on the real-time ordering on our fast flow wards. So what I've done here is just showing you the breakdown of this meal by meal. So this is the starter, and you can see the pie chart on the left-hand side is the waste before we did the change, and afterwards on the right-hand side. So before we did real-time ordering on this ward, the green bit is the amount of the percentage of the food that was eaten, and the rest of it was wasted. So the purple bit is it was served and it was wasted, so it wasn't eaten by the patient, but it was served to them. And the blue one is that it wasn't served to them at all. So after real-time ordering, the eaten portion went up to 42%. If you move on to the next slide, please, that shows us the main meal. So 39% eaten beforehand and 51% eaten afterwards. And if you could move on again, 42% eaten and 75% for the dessert. As you can see, it's had a big impact. It has made a difference. Just move on from the slide, please. There were some exacerbating factors, and as Suzanne alluded to, we're never going to get rid of waste in the hospital environment, and often that's because the patients are unwell or they're declining it for some other reason, and of course they're surrounded by people that can be unwell. So if you're in a bed next to somebody who's vomiting, for example, that's really going to affect your appetite. Sometimes people don't like the meal, it's not what they expected, and we have had, where family bring food in, so they're obviously going to eat what the family's brought in that day and not the food they've ordered. So if you move on, please. The comments from the staff that we have since, and from patients as well, since we've implemented some of these changes, are people saying that there is less waste, and patients are much happier to choose their meals off this menu. Sometimes patients don't feel like eating the normal meal, however, a sandwich doesn't fill them up until supper, so that this was definitely in terms of the food for fingers menu, so that it was a good option for that. And it's also one of the other things about was communication has improved between the ward and catering, and for the real-time ordering, the real-time ordering, yes, it gave meals out became much quicker because they weren't having to offer different choices from within the trolley. So those were the benefits that we found. If you move on, please. So overall, if we were to sum up our learning from this project and share that with you, if we look at it, there was an average of 21% less food was wasted, and as you can see there, going back to Susanna's slide, if we're looking at 30% of each meal wasted, and that was sort of replicated in fact we were higher than that when looking at the wards that we had there. So 21% is making quite a big difference. We are still awaiting those repeat audits for the other tests of change, and again accepting there's always going to be some waste, but if we can work towards reducing that, then that's a big achievement. I would say it needs a dedicated lead for the project to be effective, so we're lucky enough to have a nutritionist for part of this project, but then unfortunately Zach left us, So we were struggling in terms of that liaison with the wards and supporting them in the food waste and inputting the data, all of those kind of keeping the momentum of a QI project up. There's also lots of conflicting demands on wards, so there's a lot of QI projects going on. A lot of them are based around flow, for example, so there's lots of good work. Everybody's trying to improve things and reduce waste. So that can have the impact of the ward feeling a bit bombarded, like there's lots of things going on. We personally in this trust have linked nurses that have too many roles, and we need to relook at that. But what we are going to do is use this data gathered for a business case for electronic real-time ordering. So that there's some really good systems out there where it is electronic, so that if a patient moves wards or is discharged, then the kitchen is informed straight away, and that has been shown to have one of the biggest savings. So we'd like to use the data for a business case for that.
Yeah.
And we're building in resources for the smaller portion options as well. Okay, so that's us. Our details are there if you want to give us an email or a telephone number.
However, just to say that my telephone number on there is incorrect. So I'm 01254 732 588. So if anybody wants to ring me, it's not 4. I don't know who that is.
Okay, thank you. We'll take questions if you want to use your comment button.
Great, thank you very much, Tracy and Tim. That was really interesting, and some really positive impacts from the data that you've gathered and analysed so far. And yeah, hopefully the future data will be as positive as that. And it's really good to see that you have some future plans for improvement through the electronic ordering system, and hopefully you can put a good business case together for that. In terms of questions, I think Susanna has a couple that have come through, so she's going to just ask those now.
Yeah, thanks very much, Tracy. And Tim, I had a couple of questions, one for each of you. Tracy, you'd mentioned the importance of having a range of portion sizes, including smaller portions. And I was wondering, as a dietitian, do you have any particular concerns with smaller portion sizes?
From a nutritional point of view?
Yes, exactly, yeah.
Yeah, I mean, that's one of the debates, isn't it? So if you're having smaller portions, you're not going to meet those nutritional requirements. However, the flip side to that is, and what we see is, if you're over-facing patients with big portions, then they're not going to eat the food anyhow. So it's much better to offer smaller portions and encourage frequent eating across the day to get more nutrition into that patient. So a meal can be as nutritionally complete as you want it to be, but it has no value unless it's eaten, and I think we have to focus on that.
Thanks very much for that, Tracy. And also, of course, you mentioned the Food for Fingers menu having quite a high calorific value at 400 calories. So I guess that's one of the other ways that the Trust are helping to keep nutritional content high for certain patient groups. Tim, I just had a question for you as well. I was wondering what one element in particular has been crucial, do you think, to the success of this project?
I think it's the collaborative working, the ensuring that everybody is understanding what the goal is and agreeing how we get to that point. Nearly everything that we've done here has not been done in isolation. Everything is done from the planning of the menus right at the beginning. We ensure that we go through the BDA, and also then we meet regularly. I have a monthly meeting with speech and languages and dietitians to go through any issues we've had in the past month. And also we have an internal staff survey and patient survey for food, which included comments on the menu, and we don't get it right all the time. And we made some changes to the menus from our spring, summer to our autumn, winter menu, which included just simple things about changing the descriptor of it. Some of the dishes are exactly the same, but the description has changed, and we're getting better uptake because the descriptor has changed. So it is about listening and being part of a wider team rather than just working in silos.
Thanks very much for that, Tim. So yeah, just a really clear call for the importance of working across disciplines and that kind of flexibility to test and change as you've been running through. So thanks very much for the two of you. And again, we really welcome any questions direct to yourselves or through us afterwards. So if you're happy to mute yourselves at your end, we will move on to our next presentation. We're really keen to hear from South Warwickshire NHS Foundation Trust, who've been working for a number of years to reduce their food waste. Can I just, we're getting a little bit of feedback. Is it possible for everyone to mute themselves? Okay, thanks. So as I was saying, we're keen to hear from South Warwickshire. Karen Newman, the Hotel Services Operation Manager, was unfortunately unable to join us today, but we've been able to pre-record a presentation from Karen on the work that they've been doing, and we've also pre-recorded some questions at the end of that. So now we'll pass on to Karen. Apologies for the delay. The sign's just coming on now. Okay, thanks for bearing with us. We'll just be a couple of minutes at our end for technical reasons. Okay, thanks for bearing with us. We'll just start Karen's presentation.
Hi, I'm Karen Newman. I work for South Warwickshire Foundation Trust. I'm working local services. So, South Warwickshire Foundation Trust have been working with the Soil Association since 2014. We were a Food for Life pilot pathfinder trust with St Bart's, Calderdale and Huddersfield. This was backed by our chief exec. Initially, we were developing vending and food retail standards, improving patient dining experience, and creating food-related links with communities and partners. The group was set up by our associate director, who manages support services teams, which includes total services, dietitians, occupational therapists, physios, waste and sustainability. And this had the backing and attendance from a matron who had the lead for food. This meant we'd already jumped the first hurdle and we were working as part of a team. The areas we covered included food waste, and to get the ball rolling, we started with the workshop facilitated by the Soil Association. The workshop was well attended by our Food for Life group and also had matrons, ward and catering staff. We all had our own ideas, but we had lots to say. The workshop got us talking and helped us understand what we would count as food waste and to help us to enable to reduce waste. It gave us a platform to support staff in realising the impact and causes of food waste, so discussing over-ordering, new patients, sending food just in case, poorly patients, incorrect portion sizes, poor quality of food and incorrect food service methods. The workshop also gave us opportunity to discuss how we would audit waste and learn how to reduce waste. Steady monitoring food waste daily by our catering contractor ISS, and they were counting the number of portions left on the food trolley. we realised that the catering staff working at ward level needed some extra training to ensure they did this correctly. They weren't always putting down the correct figure, the figure that we would consider to be food waste. So we needed to ensure that they'd got the skills to monitor this correctly and report back the food waste figures to catering management. And they were also able to verbally speak to the catering managers where they think the food waste was occurring. This information it helped us produce techniques to minimise food waste, not regenerating food using historic figures, not matching orders or the number of patients on the ward. The fact that we had a lack of single or double portion packs of the food, we were using the multi-portion entrees. This also highlighted the high waste wards. We were able to start our audit by targeting these areas first. In the audits, we decided to measure the main meal of waste, and we included salads and sandwiches. And we had a plan to kick-start reducing the rather high 38% of trolley waste by setting up communications with wards and catering to enable meals to be changed and ordered at short notice. This didn't go so well, but at least it just started. Catering learned how to order small portion packs of food. However, it was the introduction of the electronic meal ordering system that really helped. It meant we could take patient food orders nearer to food service time, and we could have better information on discharges and admissions, although we still struggle with getting the wards to let catering know about this. Moving on to the next slide. So our trolley waste surveys, ISS was showing that we'd got a 6% overall trolley waste. But then when we did the trolley waste audits ourselves, we were finding, from our high waste wards, we were finding a 12% for those areas. So our plate waste was still high at 35%. But we were finding more recently, when we've just carried out a couple of audits, we were finding wards such as maternity, there was 0 plate waste, and our stroke ward, we would probably have something like 50% plate waste. So obviously we've still got work to do in understanding. And we know we've got unknown elements here, such as patients not feeling well enough to eat. They may be overwhelmed by large portions, and we need to get our portions right. We could have poor food quality issues down to not using a correct meal service. Here at Warwick Hospital, we use what we call productive meal service, where somebody who's in charge on the ward will organise the menus, call out each patient's requirements, and then hand the tray to a team of nursing who are waiting to go around the ward. But not all wards will follow this system. So that's work that we're doing at the moment. And we feel we need this productive meal service to quicken up the meal service, prevent the food going cold, losing the quality. We know that sometimes patients don't always like the choices that we've got on offer. So we regularly meet and have menu groups, change the menu. We have a patient forum who come in and help us choose what dishes we include on the menu. We understand that some patients aren't given the assistance that they need to eat, including in the opening of packaging. So this is all work that we've got that we want to carry out in the future. It works well for us to have bi-monthly meetings, which our Associate Director still chairs. And we're asked to report on our action plans and what we're doing. So we're regularly feeding back, and we're regularly having that buy-in from other parties, especially the dietitians and the ward staff. So that really helps well. So on to the next slide. So some of my top tips for you. Really, it's so important to have your directors on board with this, because that's what we found has helped us really get the group together, to get the people from other teams and have champions from other areas, because it's so difficult just to do on your own, which I'm sure you all understand that. There's a couple of us who do carry out the waste audits, and we planned our dates for the year ahead, and we try and stick to them. We had one planned for Friday, and that one got cancelled, so we're doing that tomorrow. So yeah, try and stick to those dates, and then you get as much information as you can from all of the wards. And again, as I just said, we do meet regularly, and that keeps the ball rolling. It really keeps you interested and makes you carry on doing this, because obviously we all know how important it is to try and save on this food waste. Has anybody got any questions?
So Karen, it's Susanna here from Soil Association Food for Life. Thank you so much for sharing your experiences of understanding and starting to tackle food waste at South Warwickshire. It's been fascinating to hear in a lot more detail about the journey of the Trust. And I just had a few questions for you at the end. So I wanted to kick off, Karen, to ask you what have been your major challenges then in kind of keeping this project going over the last few years?
I think it's because we're all so busy, and everyone will relate to that, I'm sure. And it's needing that high level input by having a director of support services really championing this for us. And the fact that initially we had a brilliant matron helping us, but she moved on to other things, and now we've got a new matron who is now going to take over the bit that the other matron was helping us with, really, because we need the ward staff on board with us. So I think that's really the biggest challenge.
Thanks for that, Karen. So as you say, really having that high level buy-in and support ongoing, and getting that multidisciplinary support is crucial to making things move forward. Just was interested to find out a little bit more about the audit methodology that you've been using. So you mentioned in the second slide that ISS had some figures at around 6%, but when you had gone in and done your own, if you like, independent audit, those figures have been a little bit different. So it'd be great if you were able to share a bit more about the methodology that you were using.
Yeah, okay. Well, I used your method, Susanna, which was brilliant. So we've got the two forms that Food for Life produced. So a couple of us go to the ward. It needs two people to do this, because one person is checking the food waste and the other person is checking the trolley waste. So we so say, for example, I'm doing trolley waste, so I will check the forms that the catering staff at ward level have got with the number of portions that they've recorded as being received. I check those portions and make my own comments on the form, just to make sure that they have actually got the food that they say they've got. So that's my initial part of the methodology. The other person will then check what patients are on in each bay, whether there's anybody who's nil by mouth, any special diets. And then when the food service starts, we have to check every single meal that goes out. So we list, we do a little code actually. So if it's fish and chips, we'll just put F and C, you know, but you just have to be careful there that you're not duplicating anything, because it can be confusing then when you're later typing it up. And then we wait for the food to come back, and we check what's on the plate. So we say, oh, 100% eaten or 100% not eaten, and you know, we do it in percentages. And it's a really easy way of doing it. We only do the main meal, which is you know, where the most of the money lies really. It'd be good to do the puddings, but we're concentrating on main meals now. And then I check what food is actually left on the trolley, and I check what the catering staff think is left as well, because not always now, but initially there used to be a bit of a difference. You know, I think there'd be 2 portions left, but they'd be saying, oh no, I can get 3 portions out of that, or no, actually that's only 1 portion. So we did have to do quite a bit of work on portion control there. So yes, I mean, it takes time. We go up before the food service starts, and obviously we're there until the last person has finished their meal. So it is quite a timely exercise, but very, you know, it opens your eyes, because you'll go onto a ward and you'll see how lovely the food is. We're very happy with food presentation. And then you go around and you listen to what the patients have to say, you know, so yeah, that's how we do it.
Yeah, thanks very much, Karen. It's probably worth saying for other people who are listening in today to the recording is that you've got a bulk service in place in the hospital, so the kind of methodology is very tailored towards the bulk service. That would help you to understand how correct the orders are in the first place, what's left in the bulk trays unserved, and then also, but that really in-depth look at plate waste, which is perhaps how some other audit methodologies might differ. So you do have a great sense through approaching it that way on the nutritional impacts of food waste as well for the patients who aren't eating their full meals. So yeah, thanks for sharing that. And I'll probably finish off just with one last question, Karen, and it's perhaps thinking ahead for other trusts who might see reducing food waste as a self-contained project, as something that has a start and an end date. The work is done, and then potentially you kind of tick the box, and all of the good work has been finished. So I wanted to get your thoughts on whether you feel sorting out food waste and tackling it is a kind of task and finish project, or whether you see it as something that's ongoing.
Well, I think I probably did see it as a task and finish project, but you know, experience should have told me that it is ongoing. Of course, it's ongoing. We measure the food waste daily, as I've said, by our catering contractor measures it daily. But these food waste audits are so important to keep a track of where we are, see where people have slipped back into old routines, which, you know, is only human. So you've got to keep on top of everybody all the time. And change of management on wards as well. New people come in. So it's constantly training people, going down and explaining what we're doing and why it's important. So yes, it's ongoing.
Yeah, absolutely great. Okay, Karen, thanks so much for your time today, and there will be an opportunity for anyone listening to send in their questions that we'll pass on to you, Karen. So thanks so much for joining us today. Thanks. Bye.
Thank you. Bye.
So back to our live webinar again, and thanks to Karen for that recording that she did last week. So there are some real synergies there, I think, between the two trusts that we've heard from. Particularly what stood out to me is about ordering close to meal times, what a difference that's made across the two trusts. The value of in-depth audits, the need for some menu changes, and of course that multidisciplinary approach and leadership buy-in that's been so crucial in the two trusts. So this final slide here, just wanted to make you aware of the fact that we have a new case study that's up on our website that gives a little more detail around the South Warwickshire approach. So feel free to go and to use the link on this slide and to share this case study.
So yeah, just to wrap things up really, so some of the next steps, as I said at the beginning, you'll receive an email with a link to the recording, which will be placed on our website, but you'll have to go through the link to find it because it will be hidden from non-network members. So when that comes through, please feel free to share with any colleagues who weren't able to attend. You'll also get a link to a really short evaluation survey. Like I said before, that is just six really brief questions. So if you could take the time to do that, that'd be great. And yeah, of course, if you have any questions in the meantime about anything related to network membership, then please do contact Susanna, and please do also look out for an email in hopefully before Christmas, which will give a date or a rough date for our face-to-face seminar that we have coming up in February or March of next year. So yeah, look out for that too. So yeah, just thank you for joining us really, and yeah, like we say, if you have any questions, then you can get in touch with Susanna directly, or you can just contact Food for Life, and one of us will be able to get back to you.
And thanks very much from me as well. So thank you. Bye.